Hi, everybody.
Hi.
Hi. Hi. Welcome. We're going to wait a few minutes here and let our friends join us, and then we'll get started with our Midwifery Week celebration. Yay! I feel like I should sing or something. Oh, wait. But nobody wants to.
No, wait. Excuse me.
Welcome, everybody. We're going to get started in just a minute. We are celebrating Midwifery Week 2020 with your neighborhood midwives here. So welcome, and we encourage you to have fun and make some comments, ask some questions, and we're going to get started in just a little bit, okay? So welcome.
Hi, Megan and Diana.
How can you see? As you can see, we have our lovely midwives here, Nadia, Emily, Julie, Kate, and myself. We're going to get started in just a couple of minutes. Oh, there we go. Okay. Hi, Megan. Hi, Bea. Hi, Dan. Hi, Diana.
Hi, Christina, if you're there.
Hey, Kristen. Oh, look how cute. I love the picture. So chunky, the little baby. Oh.
It doesn't seem like these babies should be this big.
I know. Oh my gosh. I love the baby pics. They're awesome.
Hi, Stacy. Great. So yeah, put your comments in the share your pictures of your babies or any questions that you might have. We have a good agenda coming up with some really great information that each of our midwives have prepared for each of you to be able to keep really good track of your health and all those things that we need to do to keep ourselves healthy, especially in this time of our lives. So we'll get started in just about a minute, okay? All right. So we're going to start out by saying Happy Midwifery Week 2020. Yay.
Yay!
Right. So tonight we're going to just introduce ourselves a little bit more to you. Some of you we already know really well, and we're so happy to see you back. We have a new face with Nadia Robinson here, and she'll be doing a little introduction, as will all of our midwives, so you can get reacquainted with us. We have some great presentations around cervical cancer and screening, around birth control, pre-pregnancy health, and postpartum, and we'll also be answering questions at the end of any questions you have about your health and how to stay, as positive and healthy as possible in these times. So just going to get started by having the midwives introduce themselves. So we're going to start, I'm going to start with Julie Kellen. Julie is our midwife that's been with Neighborhood the longest.
Also, that means I'm the oldest, which I wear that title proudly. I am Julie Kellen. I have been a midwife since 2000. January of 2000 was when I got my degree. So 20 years, caught lots of babies, and I've been at several different hospitals and different practices, but I've been with NFP for 10 years now. And love being here, love you all, love our patients, love the people I work with, and love being a midwife more than anything, obviously, because I've been doing it for 20 years. So, yeah.
Julie, can you tell us what some of your special interests are as far as in your practice and kind of what you have developed as your special kind of things over the years?
Mm-hmm. So I've done a lot of studying with pap smears, which is what I'll be talking a little bit about tonight, specifically with colposcopies. While I don't do colposcopies, I do know quite a bit about them. So any questions that people have about them, I'm more than happy to answer. I also have done quite a bit of studying in sexual health, and that's an interest that I have, or I have a great deal of interest in that, and really enjoy helping people if they're having any issues with their sexual health. So those are two main areas that I've really kind of focused on.
Mm-hmm. Great, thank you. Thanks. So I'm going to have Kate Lawrence go next. Kate has been with us for 5 years now. So Kate, you can go ahead and introduce yourself.
Hi, everyone. Yeah, I think just over 5 years, almost 5 years full time. I obviously love it there, as we all do. I was a labor nurse before starting at Neighborhood at Metro for 13 and a half years. So been working with moms having babies since 2002. Seems like almost 20 years, I guess. So let's see. This has been my my kind of I don't know how to say it. What brings me a lot of joy in life lately. So I really appreciate. I've had a lot of wonderful births, and it's really helping me just know that there's all kinds of great things in the world, especially with what we're doing, being midwives. So.
Great. Thanks, Kate. Thank you. So next, I'm going to move on to Emily Leslie. Little known fact, Emily, Leslie, and I actually were in the same midwifery class together. So we were baby midwives, and now we're grown midwives.
Yeah, sure. Yes. So I am so lucky to be working with Katie again. I remember being in school with Katie, and Katie just going on and on about how great Neighborhood Family Practice was because she was working there as a nurse at the time. And so I'm just thrilled to have been able to join the group. So I have been with Neighborhood Family Practice for 3 years now. I previously worked at university hospitals in Cleveland before that for 4 years. So I've been east and west in Cleveland. My areas of specialty, or my areas of special interest, I would say, are family planning and pregnancy options counseling. I really love doing limited OB ultrasound, which we've been able to implement at Neighborhood Family Practice, that I'm really excited about. And I'm also really interested in LGBTQ care and trans care, gender affirming care, and have been doing some training around hormone therapies and things like that for trans folks. So that's kind of where my interests lie. But of course, I also love catching babies and being up all night and the adrenaline rush and all of that. So, yeah.
Thank you, Emily. We're so happy you're here. I'm going to put up Emily Sadri's photo real quick. Many of you know Emily Sadri. She's not with us tonight because she's home snuggling her own beautiful baby, Sai. So Emily has been with us close to 5 years as well. And Emily has some interest in functional medicine. And she's also, congratulations to Emily, a new lactation consultant. She passed her IBCLC exam, which is awesome. So she has great interest and is a huge resource for us with breast health, along with Lauren Lasko, our nurse practitioner here in our Amby Reichsman Center, who helps us and helps our moms have successful and positive breastfeeding experience. So hi, Emily out there. We miss you. And hopefully you're home snuggling your baby. And then I'm going to introduce, last and certainly not least, our newest member of our team is Nadia Robinson. Nadia, we've known actually for a really long time. Nadia was a volunteer doula with us years ago and worked in the community. She went back to midwifery school. She's a nurse midwife and actually also a family nurse practitioner. So Nadia, welcome, and tell us a little bit about yourself.
Thank you. So Katie just took my whole introduction, which is fine. Except that now I don't have much to say. I'm a brand new midwife, so a lot of the things that I feel interested in, I don't have a lot of background in. But one thing that really draws me is musculoskeletal health. I'm really fascinated by the way that we can help get people comfortable prenatally and also help their babies to then be in a great position to be able to come through the pelvis easily during labor. And so I hope to go back to school at some point for some training in massage therapy. Also really interested in functional medicine. I think that there's, I feel like that's a new frontier for how we can approach stuff that often doesn't have an obvious treatment. So yeah, so that's me. I'm really happy to be here. Thrilled.
Great, and we're happy you're here.
I also worked with Nadia in a past life and in family planning and pregnancy options care. So it's nice to be reunited with some old buddies. So
great. And I'm Katie. I think I've been here at Neighborhood 15 years, and I grew up here at Neighborhood and became a midwife at Neighborhood after doing family planning for a long time. But I'm super passionate about midwifery care, and I am totally committed, along with this amazing group of women on your screen right now, at providing really sensitive, comprehensive, and great care to the people that we serve every day. And I think from what you just heard there is that midwives do a lot more than just catch babies, right? Look at all those things that we're interested in: sexual health, cervical cancer health, and women's health, and gynecology, and all of those different arenas and things. I think that we can provide services in a lot of different ways. So The last person that's not on our screen but is an important part of our team is Dr. Natalie Adswar. She is a Cleveland Clinic OBGYN that comes out to our office twice a month to see people for their gynecological issues and also obstetric issues that are a little bit more complicated, and that she can consult with our people right here in our office and provide the same amazing care that she would in her Cleveland Clinic offices. So we're super happy to have her a part of our team as well. So on that note, we're going to get started. Just if anybody has any questions, if you want to throw a picture of your baby up there for us to ooh and ah over and take a look at, or if you have any questions or about your own women's health care, feel free to put that up there and we can answer those questions. So on that note, I'm going to kick it off to Julie, just because she's first on my list over here. So Julie's going to give us a little talk about cervical cancer and some of the new recommendations and things and such. So Julie, take it away. Julie, you're muted. I'm going to unmute yourself and start over.
I'm so sorry. Yes, I'm back. So as I was thinking about tonight, I guess I was thinking it would probably be a little more interactive, and then I'd be asking a lot of questions, which I guess I won't do. But cervical cancer is something that is that we have actually been able to really address significantly and decrease the amount of cervical cancer that's out there because of pap smears that we've been doing over many years, and a lot of that we've learned over many years. So the cervix, just a quick anatomy lesson. The cervix is the opening of the uterus, which is inside the vagina, and the cervix can develop cancer. We can develop cancer in all of our female organs, but the cervix is one that we are able to address pretty easily. What we have found over the years is that HPV, or human papillomavirus, it seems to be the main culprit in women developing cervical cancer. One of the reasons why we've had such great success in addressing cervical cancer is because it is very slow growing. So as long as women are good about getting their pap smears regularly, we can usually catch it if there's something, if the cells are starting to change and starting to become more abnormal and moving more towards cancer. So the way that we test for cervical cancer is we do a pap smear. So what is a pap smear? A lot of women think that a pap smear is when we put that little duck-billed thing, the speculum, inside your vagina and get a swab. But and a lot of times women think that if they've been to the emergency room and they've had that speculum put in them, that they've had a pap smear done. But that is not a pap smear necessarily. A pap smear is where, yes, we do use the speculum, but we go into the vagina and up towards the cervix, the opening of the uterus, and we scrape some cells off of the cervix, and the cervix is like a little donut, and so there's like a little tunnel here, and we get some cells from the inside of that little tunnel as well. And then we put those in some solution and send that to the lab, and the lab looks at it under a microscope, and they're looking to see if the cells are becoming abnormal, if they don't look like normal cervical cells. And as I said, HPV, human papillomavirus, which is a sexually transmitted infection, seems to be what causes changes to happen within those cells in the cervix. So we do this pap smear, we send it to the lab, they look at it under the microscope, and if there are any cells that are abnormal, then we will either increase the frequency that we look at, that we repeat there. We'll repeat that pap smear sooner, or a woman might be referred to have what's called a colposcopy done. There are a large number of, there's a spectrum of changes that can happen within those cells, going from being normal all the way up to cancer. And those changes start off The hospital is calling me. Kate, maybe you could take that. The cells start to change. There are minor changes that happen first, and then they become more major and more severe, and then eventually cancer. By having the pap smears done regularly, we can catch those changes when they're in the early stage, and then we can address them either with a procedure or sometimes they resolve on their own. Sometimes that HPV will go away on its own. So questions at this point about what I've talked about? Midwives, any input at this point? Okay, so
does it hurt to get a pap, Julie?
Well, the speculum is not particularly comfortable. So nobody likes having that. I've never, ever had a woman lay down on the table and say, oh, I can't wait to get my pap. It's not a very pleasant thing to have done. It's awkward. But we try to be as gentle as we can in putting the speculum in. We can use small speculums. The pap smear itself, like scraping the cells off of the cervix, we use a very soft broom, it's called. It's plastic and it's very bendable. And that generally doesn't hurt. It might be a little bit crampy. It's really more the speculum that's uncomfortable, but it's a quick procedure. So generally it should not hurt very much.
Julie, there's a couple questions real quick. One is, can you still get cancer if you've had a hysterectomy?
That's a great question. It depends on what reason you had the hysterectomy for. If you had the hysterectomy because you'd had cancer in the past and they were removing your uterus to get rid of that cancer, then it is possible that you might get cancer again. But generally speaking, if the hysterectomy was for, say you had fibroids or heavy bleeding or prolapsed uterus or something along those lines, then the chances of developing cervical cancer are very remote because they will take that cervix typically.
And one other question here, how often do we need pap smears?
So we used to start pap smears as soon as women became sexually active, but the research, we've done so much research, we've discovered that we were doing unnecessary procedures on women, and we really don't need to start pap smears until women turn 21. So that's the age when a woman should have her first pap smear. And then in your 20s, it should be every 3 years. Once you hit 30, it goes to every 5 years until 65. And then you don't need a pap smear anymore, unless you've had abnormals. If you've had abnormals, then you'll need to have potentially more frequent pap smears, and you have to be 20 years without any abnormals before you can go to no pap smears. Any other questions?
Great. Thank you. Thanks.
That's a lot of pap smears.
It is a lot of pap smears.
Yeah.
Get to know your midwife well.
Great. Well, thank you, Julie. Thank you very much. And thank you to Lauren and Diana for your questions. We're going to move over to Emily Leslie, and she's going to be talking a little bit about contraception. And Emily, take it away.
Hi, everybody. So family planning and contraception are some of my kind of favorite areas of interest. It's gotten to be really cool because there used to be a day when, pills were the only option or condoms were the only option. But, this is an area where medical technology has really served us well in expanding the options that are available to us for contraception. So when we call it contraception or we call it birth control, generally we think of, preventing pregnancy, but that's only one of many reasons that somebody might be using one of these medications or devices or methods. So That's probably the most obvious is for pregnancy prevention. And there are a variety of ways that those methods work to prevent pregnancy. But many people also use different types of birth control or contraception as ways of controlling their cycles. So, if you have very heavy periods, very painful periods, a lot of times we can use birth control or contraception either to make your periods lighter or to make you stop having a period. A lot of people will use contraception also to help regulate their cycles. So, if you get 2 periods in a month, or if you get, 1 period a year, neither of those are great circumstances when they're happening, naturally on their own. We do, we would generally be able to provide you with some kind of contraception that is safe for you and can help to regulate your cycles so that you're not dealing with that kind of unpredictable bleeding. So there are a lot of different ways to kind of choose what birth control is right for you as well. So, along with pregnancy prevention, because there are so many other reasons that somebody might use birth control, it's really going to vary a lot what you choose. So a lot of people will come to us and say, what's the best birth control? And there really isn't an answer to that. So the best birth control is the one that works for you and gives you the benefits that you're looking for. So, if you're looking for pregnancy prevention and that's the most important thing to you, we can talk about what kinds of birth control are the most effective at preventing pregnancy. There are a group of birth control devices that are referred to as LARCs. They're long-acting reversible contraception. So what that means is long-acting. So you don't have to take a pill every single day or come in and get a shot every couple months or, put a patch on every week. You just think about it every once in a while, usually every couple of years. And they're reversible contraception, meaning it's not like getting your tubes tied or getting a vasectomy. You can still have children in the future if that's something that you want. So those include things like an IUD. There are a couple of different types of IUDs and of course, we're getting more and more IUDs every day as, the FDA approves new ones and things like that. But basically, there's hormonal IUDs and non-hormonal IUDs. So an IUD is a device that goes inside the uterus. We insert it in the office. It's a pretty straightforward procedure. Feels like a couple big cramps as it's inserted, but we just insert it using a little tiny tube going through the cervix. Using a speculum like what Julie was talking about to kind of hold open the walls of the vagina to be able to see the cervix. That little device sits inside the uterus and it stays there depending on which method you get, which type of IUD you use. It can stay in for up to 3 years, or some you can keep in for up to 10 to 12 years. The nice thing about the IUD is you can you don't have to think about it. Once it's in, it's in. You can get it taken out anytime and your fertility returns normal following its removal. It works really, really well at preventing pregnancy. So it's one of the most effective reversible methods of birth control. So that's become a pretty popular option for a lot of people. The other LARC that we commonly use, the long-acting reversible contraception, is called the Nexplanon. It's a little device. It looks like a matchstick. It's made out of plastic and it goes right in your arm here. We insert it using a little needle in the office and we numb up that area before we insert it. That device has hormones in it. It has progesterone only, so it's safe for women who are older, who are smokers, things like that that might otherwise make you at higher risk of blood clots with certain types of birth control. So that's a nice reason that many people choose that option. That is the number one most effective reversible method of contraception when it comes to preventing pregnancy. So those are kind of our big three that we go to if you're saying that the most important thing to you is preventing pregnancy. Of course, any birth control is going to have side effects as well. So it's a matter of finding something that works for you and also has acceptable side effects, if any. The most common side effects with the IUD that we see are some cramping, which is very, very common and very normal, especially for the first 3 months or so as your body kind of adjusts to it. And you can have irregular bleeding patterns. So especially with the IUD and the device that goes in the arm, the Nexplanon, we often will see irregular bleeding, like bleeding in between periods, a little bit of spotting all the time every day, or some people stop getting a period altogether. All of those things are perfectly normal. So it's just a matter of whether you are comfortable tolerating them. So a couple of the other methods of birth control that are kind of the next step down as far as how effective at preventing pregnancy would be things like the depot shot. So that's when you come in and get every 3 months. That's one sometimes we'll use to help control bleeding, and same thing with the IUD. So if somebody says they get super heavy periods or really irregular or unpredictable periods, sometimes we can actually use the fact that the IUD or the shot or the implant in the arm can stop your periods. We can use that to our benefit. So that's one kind of benefit to that for a lot of people. Now, unfortunately, one of the side effects is sometimes instead of stopping your period, it makes you have that irregular bleeding, unpredictable menstrual bleeding, spotting all the time. People will say, I've been getting my period for the last 2 months. Now, it's not technically your period, but it is that kind of irregular bleeding that can be very annoying and frustrating for people to deal with. So, but, again, it's a matter of finding an option that works for you. And people like that because they're in control of it. You come in once every 3 months and get it yourself. The kind of next tier would be the things like pills. So we call those combined oral contraception, or you can also have progesterone only pills. So people say I was on the pill and didn't like it, but we actually have about 100 different types of pills. So if you found a pill that didn't work for you because of side effects that you were having or anything like that, we can try a million different types of pills until we find something that works for you. One problem with pills sometimes is that people have trouble remembering them, which is what makes them a little bit less effective at preventing pregnancy. Is you have to take them at the same time every single day. And for a lot of us, if you have kids, if you work a weird schedule, yes, same. So that is not feasible to take a pill at the same time every single day and never miss. So that's and some people really like to have that level of control over their fertility and over their cycles and things like that, to be able to say, what, I want to get my period right at this time, so I'm going to stop taking my pill during this time, or I don't want to get my period when I'm on vacation, so I'm going to keep taking my pill through vacation, so that's kind of nice. You really can have a lot of personal control over it versus something like a device that we put in the office. So that's another place where if you have if it's important to you that you are in control completely, that may be a better option for you. So.
Emily, I'm going to sneak in real quickly. I'm going to say goodbye, everybody. We have a mom who's just shown up at the hospital, so I need to run. I'm on call. So it was lovely chatting with you all. It's a good thing I went first.
Happy birthday, Julie.
Have a great night.
Julie.
And
happy
birthday, Julie.
All right. Bye, guys.
All right, so, Emily, we had one quick question from someone, and then we're going to move along a little bit. We'll answer this question real quick and then move to Nadia. But there's a question about, at what age should you start talking to your kids about contraception, which I think is a great question.
Yeah, that's a really, really great question. And a lot of that is going to be, personal preference, what you're comfortable with for your family, what your personal values are. I will say, as a medical professional, I think that the more information people have, the better. I think talking to people when they start hitting puberty is kind of a natural time to talk about it, when you're starting to have these conversations around your menstrual cycle, talking about, how babies are made, the feelings that you start to have about other people that are maybe more than friend feelings. I think that's a natural time to start to talk about it. And there are age appropriate ways to introduce that. So you can start by just saying, there are things that you can do to not get pregnant if you don't want to be pregnant. You don't have to dive right into, here's the pill and the IUD and the patch, and that can be overwhelming for a 12-year-old. But knowing that those options are available is huge. That's always something that we love to do too. I'm really interested in adolescent health, and so having consultations with a medical provider sometimes is easier for young folks to ask questions, to hear the information that maybe they don't want to hear from their parent about contraception. So, again, in my opinion, I think that it is not ever too early to talk about contraception, and there is a way to do it in an age-appropriate way, where it makes sense for where that kid is in their development. So, but we do know from a lot of research that talking about birth control, talking about safe sex practices does not increase the likelihood of somebody having sex, but it does give them the tools to be able to make safe choices if and when they do decide to have sex. So I think it also does a lot for empowering us to, recognize the control that we have over our own bodies. It's pretty cool that we can do all these things to kind of, manipulate our cycles and manipulate our fertility to be able to create the lives we want for ourselves. So.
Thanks, Em.
Yeah.
Thanks, Emily. Yeah. I always find it, people get really surprised that midwives are just as interested in preventing pregnancy as we are in catching babies.
Yeah, we often joke every time we put an IUD and we're actually losing business for ourselves.
What we really, really care about is that people have options, and that people feel respected and heard as to what is best for their families and for their bodies and for themselves, and that they can make really great choices with all the information that's needed. So thank you. Thanks, Em. And Nadia, we're going to move to you for your quick presentation here about super important topic, which is postpartum care. So go ahead.
Yeah, in case the birth control doesn't work out or you are choosing to get pregnant, postpartum is an inevitable part of that. So I'm going to work my way from the bottom up. Please appreciate my pun. So starting out talking about urinary incontinence a little bit, I just want to put a public service announcement out that although it's really common, about 1 in 3 people experience some urinary incontinence after they've had a baby. And as much as we love vaginal birth and support people to have a vaginal birth if that's what they desire, it is more likely that you'll have some urinary incontinence if you've had a vaginal birth versus a C-section. But it's possible after both, and just having a pregnancy that goes full term actually increases your chance of some urinary incontinence. So can't completely weasel out of it. But although it's super common, it doesn't have to be considered normal. So that is to say that there's things that can be done to help. So a lot of people have not heard of pelvic floor physical therapy, but it's just what it sounds like. So somebody that's really, really, really knowledgeable and trained in how to support people in getting from point A to point B in whatever their goals are. It can be helpful for pain, but for urinary incontinence, it can be really useful. So we can provide a referral to that if that's something that you or someone you know is experiencing. And then up to the breasts. So breastfeeding, same kind of thing. I think that there's some misconceptions that can sometimes make breastfeeding more challenging, which is that pain is normal. Some tenderness and an adjustment period for the nipples is normal, but pain is not. So just to say that if that's happening, or if there's anything that feels like it's different than what you had envisioned, that there's support. And another, I think, really common misconception when it comes to breastfeeding is that supply is a problem. So not being able to make enough milk to feed your baby. A lot of people know someone or had a family member or had their own experience of not being able to make enough milk. But only about 5% of people are born with something that's true about their body that makes them unable to make enough milk. And most other people can get help to make some changes that could be supportive of them being able to successfully breastfeed. So just a plug out there that, you know, we can provide you with a referral to a lactation consultant. We have an amazing lactation consultant here, and obviously one of our midwives is an IBCLC. I think you are too, Kate Lawrence, is that right? Two of our midwives. And even during this time where it's not as safe for us to bring people into the office, we're doing telehealth, which is fabulous. Even if it wasn't during, you know, a global pandemic, it's sometimes just really useful to be able to stay at home and have somebody watch you, nurse, and give you some pointers or just give reassurance. Sometimes that's all people need. And if you need more reassurance than that, or if there's really a concern from a provider, another thing that can be done is to bring you into the office, have somebody watch you nurse. We can weigh the baby before you nurse and then after, and we can actually see how much they got. So just to say that there's a lot that can be done with good support to give you confidence and also give you help to have things be comfortable and, you know, and successful. So,
and just to add one thing to that, Nadia, one thing that I hear a lot from people is that they say, you know, I didn't have enough milk to feed my baby, so I switched to formula, or I was going back to work, so I switched to formula, or, you know, it was too stressful, so I switched to formula. And a lot of people have been surprised when I say it doesn't have to be all or nothing. So any little bit of breast milk that babies get is awesome. So if it makes sense in your life, or because of your goals, or because of how much you're producing, you know, you end up supplementing with formula, it doesn't mean you have to stop breastfeeding. There are many people who use formula while they're at work and they nurse their baby in the morning. And, you know, that works for them. So you know, it's a spectrum of finding what works for you and what works for your baby. But it doesn't have to be all or nothing. It's not breastfeeding or formula. It can be both if that works for you.
Totally. Or bottle feeding formula if it works better to just pump. So lots of ways to go about it. And there's really good help. So, and then the last thing is moving up to our minds, our brain. We know that about 1 in 7 people experience postpartum mental health challenges, whether that's anxiety, depression, or something else. And so just thinking about some protective factors for that, obviously sleep, or maybe not obviously. One of the most protective things that you can do is just protecting your sleep. So asking for some help so that you can get rest as much as possible after that baby comes. And that kind of brings me to my next point, which is adult support and connection. And I say those 2 words because I think they're different things. We know that it's helpful to have someone to pass the baby off to so you can shower, or so that you can, you know, get some help around the house and not have to be doing every little thing. But connection is another thing that we need. Sometimes you want to hold the baby, you don't, or you want to fold the laundry yourself, but you want somebody to be there just to have a conversation with you as a human. And especially right now, I think that that's something that requires a little bit more strategizing. And so in some ways, I feel like this time makes it easier for families to set some boundaries around when people will come to the house to see the baby, or to see them. And in other ways, I think it makes it really challenging to think of having people in your space as even an option. One thing that's true, though, is that it's recommended that for the first couple of weeks, you kind of steer clear of other folks, because newborns are just not born with a super strong immune system. So that happens to also be the period of time the CDC is saying, if you quarantine, you can know that you don't have COVID. So that's one way that you can think about that postpartum time. I think it's useful to always have some people that you know are going to come for that first 6 weeks. Somebody that's going to be there for a few hours just to be with you or to help around the house. And so that can be something that you do to continue to have people in your home if that's what you choose to do and you feel safe with that. Scheduling that out and having them quarantine during that time, that 2 weeks prior to coming to help or to just be with you. And then if that's not in the cards or you don't feel comfortable, having still some intentional connection digitally. So texting, FaceTiming, whatever it looks like for you, being aware of what your needs have been before when it comes to having connection, and making sure that you're maintaining that because you deserve it. And we need each other, even though we have to be mindful about how to keep ourselves and our babies and the people we love safe. So I think that'll be really important this season.
Oh, thanks, Nadia. That's really great advice. And I think really that personal connection is so important. However you can get it. And we often have a saying. I tell everybody that I round on postpartum, just because you had your baby doesn't mean we go away as midwives. You can still call us. We touch base. That postpartum experience and that time is so important. So thank you very much. And I'm going to just touch really quickly, as I'm cognizant of time, around planning for a pregnancy and some preconception information. So as we know, babies sometimes just happen, right? I know it happened to me, and I was the family planning nurse. That was my job, was to talk about birth control all day long, and I accidentally got pregnant. So if it can happen to me, it can happen to anybody. But there are some things, if you are at risk for becoming pregnant, that we would love for you to be mindful of. And one of those is making sure that you are getting enough folic acid in your diet. Folic acid is it's a component of dark green leafy vegetables and good foods. And what we know about fetal health, or the initial growth of the baby, is that eating or taking 400 micrograms of folic acid can help prevent neural tube defects, or defects of the spine and the brain development of the baby. And so if you are at risk for pregnancy, that means not using birth control, having unprotected sex, or planning a pregnancy, that even before you get pregnant, you should be using 400 micrograms of folic acid every day. Also, a visit with your midwife, with your primary care provider, to talk about risk factors as far as a future pregnancy, including maybe you have some hypertensive, high blood pressure issues, or diabetes issues, or other chronic health problems. We can talk about that and talk about how to help your body be in the best position for a healthy pregnancy and a healthy baby. So we are more than happy to do those consultations for women as well. And we love to meet you and talk to you even before you have your baby. So that's my little 2 cents on preconception. So Madison that's the end portion of our talks about the educational portion of what we've been doing today. So we still have a trivia contest coming up and a little Q&A session as well, if anybody wants to ask any further questions in the comments. Okay, so we're going to go with the trivia questions next. Okay, so I'm going to say the trivia question and the first comment are going to be the winners of our gift cards for $100. That's like an impressive gift card. I know, this is our midwifery week celebration. In the past, we've had lunches, we've had movies, this is so our whole budget is going to these gift cards today. So you guys are all the lucky winners. So let me look at the trivia questions here. We'll ask them here. Let me see. Oh, they're not on this printout, are they? I will find it in 1 second here. My apologies. See here. Talk. Okay. Okay, so here is our first question. First question is, how many babies did the neighborhood family practice midwives catch in the year 2019? Guesses in the comment section. Closest to the number without going over is the winner. So exciting. Should ask, I don't know, which midwife caught the most babies in 2019, do you think?
That's a good question. I was out for maternity leave, so probably not me.
I feel like no matter what, you always catch the most babies. You're the baby magnet. Even though we might share call equally, you are the baby magnet.
A lot is 10. The right answer, Claire.
I'm like 10, 20, 30.
I have one guess. We'll leave that open. Everybody put your guesses in there. Claire guesses 150.
Katie, can you repeat the question?
Sure. How many babies did the neighborhood family practice midwives catch in 2019? Joyce has a guess. Okay, we're going to move on to the next question. And we'll close that question out in about 2 minutes, Madison, okay? So the first question was, how many babies did neighborhood family practice midwives catch in 2019? And we say catch because, as Lauren said up here, Julie delivered her baby. Julie did not deliver her baby. Lauren delivered her baby, and Julie caught it. So second question, at what age should a person start to get their first pap smear? At what age should you start getting your cervical cancer screening? Thank you. You forwarded them to me.
Katie, we can't hear you. I don't know if you're muted.
Oh my goodness, I'm so sorry. I'm trying to. So the person that answered correctly, we had 219 births in 2019. The answer correctly, closest without going over, was Claire. Yay! And then the first person to answer correctly on our pap smear screen was Jessica Shattuck. Yay, Jess! No, you do not have an unfair advantage. You are right on and was first to answer. Yay. And then the third question tonight is, what is, and we haven't touched on this yet, so this is a good one. What is the leading cause of death for women in the United States? Not a very fun question, but super duper important. What's the leading cause of death for women in the United States? First person to answer correctly will get the last gift card. So, and again, I apologize for being muted earlier. I'm often like to say I didn't join the world's oldest profession to be a technological wizard. So we are working here and doing our best. So any ideas? Yeah, Claire wins again. Yay. Awesome. So we do have, thank you all for participating. That was super fun. So we've got about 5 minutes left. We're going to do a few of these questions. Audra, do you want to pick a couple out? You've been looking at these questions. Pick a couple out, or do you see any trends or anything that people are wanting to know about? And then our midwives can answer some of those.
I think, Katie, there was a good question in terms of we've talked a lot about pregnancy and birth control. Do the midwives see women who are in the throes of menopause?
Yeah.
Yes, absolutely. Yep.
Absolutely, we do. Yes.
We are with women and with people throughout their lifetime. So basically, puberty, adolescence, all the way through menopause. So
here's a good question. I know that this has been a topic during Breast Cancer Awareness Month. I have dense breast tissue. Should I be demanding an ultrasound? I've heard that mammograms can miss tumors in dense breast tissue.
Can I chime in?
Yes, of course.
Yeah.
I was just working with a patient this week that had some risk factors, but was young enough that she probably had dense breasts, because most of us do in our 20s and 30s. And it is actually seems to be a better test to get an MRI with a mammogram if you are somebody that's at high risk and could use, screening for breast cancer before you're at an age where that breast tissue has thinned out enough to make mammogram effective. And that might be an option that you could explore with your provider, even if you were at the typical age to start mammogram screening, but had some breast tissue that was still dense enough that you were concerned about it. So MRI with contrast plus mammogram has been found to be able to pick up more than one or the other alone.
Great.
And if you're not sure if you have dense breast tissue or not, you can do routine screening by mammogram, and generally they will give the feedback that they didn't get good visualization by mammogram if that's the case. And you can do additional screening after that if needed.
Thank you. And then another birth control question. Can taking birth control too long lead to infertility?
Emily, why don't you take that one?
Yeah, so there's no reason that birth control should impact your fertility at all, is the short answer. Many women are on birth control for years and years and years. What that doesn't mean is that everybody who's on birth control for 15 years, when they go off of it, they'll be able to get pregnant right away. But it's unrelated to the birth control, if that makes sense. So, when you go off of birth control, your fertility goes back to whatever it would have been previously. But for some people, that's, lower fertility. So, as we get older, we become less fertile generally. And there are a number of other factors that can impact fertility over the years. So sometimes just as we get older, we're not as fertile as we were when we were younger. But birth control itself does not impact long-term fertility. The one caveat to that I do warn people about is with the Depo-Provera shot. It is perfectly safe to use long-term and all of that. But there can be a delay in the return of your fertility after you go off of it. So if you're planning on becoming pregnant in the next year or so, the Depo shot that you get once every 3 months may not be the best choice for you, just because some people do get pregnant right away if they miss their shot by a couple of days. But some people, their periods don't return to normal, which means their ovulation doesn't return to normal for even several months after getting after using the depot shot. So if you are planning a pregnancy in the near future, you may want to consider a different method of birth control than the depot shot, but it doesn't impact your long-term fertility. It just takes longer to return to your normal baseline, if that makes sense.
Great. Thanks, Em. And also, I just want to thank you for that information. Claire messaged us, and she is going to give back one of her gift cards to the person who gave the second answer. So that was Brenda. Congratulations, Brenda, and we'll be in touch with you. All right, Audra, well, looks like we're close to being, it's 8 o'clock right now. Do we have 1 to 2 more questions? Time for 1 to 2.
There is a question regarding birth control as an option. Is it an option for young teens who are experiencing heavy bleeding and irregular periods?
Absolutely.
Yeah, I can take that. Yes. We will often use, sometimes going on birth control can help to regulate a period. It can also help to minimize some of the thickness of the lining of the uterus, which causes a heavy period. And, you know, as Emily mentioned earlier, there's a lot of different options for how those hormones to regulate those periods get into a person's body, whether that be pills or the NuvaRing or the patch, but there's different ways that you can, use those methods to regulate a period. And it's teenage time is hard enough, I think. Sometimes if we can help someone to have a bit of an easier time, we know that it is safe for teenagers to take if they come in for consultation, and we can help them meet criteria, to make it safe for them to take birth control. It can really be a great option for them.
And just to add on to that, the IUD, the one that goes into the uterus, it used to be said that people would only provide it to people who were married or people who had had babies before. And that's kind of the old-fashioned way of thinking. All of the research that's come out in the last several years actually shows that it's an incredibly safe and effective method of birth control and regulation of cycles for young people as well. It's now considered the first-line treatment for the first line method of birth control for adolescents. So it is perfectly safe, and that is an option for people even when they're young or not partnered or haven't had babies before.
Great.
That's all the questions we have this evening.
All right. Well, thank you everyone for coming. It's so great to see you all. And thanks for celebrating Midwifery Week with us. And
thank you.
Hope to see you soon.
Thank you.
Thanks everybody.
Bye.
Bye.